So let's start just with something really basic, which is when a patient first comes in with macular degeneration, what type of studies do you get? How do you verify the diagnosis?
Patient first walks in with macular degeneration or loss of vision. I will first, obviously, you have a history, points like that. We do an exam, and usually at that point you have a high suspicion for neovascular macular degeneration. We will get fluorescein and spectral-domain OCT and volume scans. Those are usually very helpful to highlighting the disease that they have. It usually confirms that they have neovascular AMD, or in some cases variants like vitelliform or high-risk drusen that are masquerading.
Well, and you mentioned specifically OCT. What scans are you looking for? What views do you usually get?
So I get a volume scan of every patient. The days where we did fast maculas with the old Stratus or single line scans, I literally never order those anymore. I want a view of the entire macula, and that usually helps me to fully assess what's going on. Too easy to miss disease with single line scans.
Do you look at all the scans? Do you have reader software in your office?
So I have reader software in the office. I will look at the entire scan of every patient. But these days, the scan, it's shot in the photography suite. It comes into your exam lane, and it's very easy to review. And with current speeds and such, it's quick. And patients really appreciate understanding and seeing what you're looking at.
Particularly in AMD, the number is there, the quantitative number is there to tempt doctors into creating malpractice. We're radiologists. We have excellent scans. If you don't look at all the best high-resolution scans, you are not giving your patient the best care they can receive.
And I would just add that if somebody comes in with any kind of visual complaints and the OCTs are done, and sometimes you have a hint that there might be some fluid, but you're not absolutely sure, I will always get the fluorescein, because I feel like in some cases even the OCT might miss a little area where on the fluorescein you might see an area of increased hyperfluorescence with some very late leakage, and that will prompt you to then classify that patient as neovascular and then make decisions about treatment. So I still think that in the era of SDOCTs, high-resolution volume scanning, fluorescein still has an important role in making the diagnosis.
I think there's a difference between new patients and established patients. A new patient in my clinic always gets both when there's a suspicion. The established patients typically come in, and in many cases, if not most cases, they already have a spectral-domain OCT volume scan. We look at that, and that usually triggers getting the fluorescein after.
So, Carl, you brought up that you use fluorescein. In the past, with macular degeneration, it was very important to get a fluorescein to sort of determine the lesion composition. Do you think that plays as much a role in current management of AMD?
No, I don't think the lesion composition is as important as it was in the past, because the anti-VEGF seem to work across all classifications. The only caveat to that is if there's some features on the fluorescein that might prompt us to think about polypoidal, for example, then that's one classification where I might be then prompted to get an ICG. So if there's some issue on the fluorescein that would let me think that it's polypoidal, then that's the one subcategory that I think it's important to identify.
Would that change your treatment, though? I mean, I still look at those patients and treat them with anti-VEGF,
right.
and then...
Yeah, exactly. I mean, the first approach is always anti-VEGFs, but already I'm having a discussion with the patients, because clearly a lot of the patients know about anti-VEGFs.
David Boyer, did you have any other tests that you use for diagnosing macular degeneration, or do you just stick to ones we just mentioned? No, are there any others that you would add in there?
No, basically, I would do pretty much what Jeff outlined and what was outlined. I think in the patients who have definite polypoidal disease, we know from the Everest trial that the results using anti-VEGF therapy were equivalent to using PDT, but that the polyps seem to close down better, but we don't have any visual change. So I think aflibercept may work better in that, and I'm not sure I know the reason why, but it seems, at least in our hands, that aflibercept for polypoidal disease may be a better treatment.
Peter, one other thing that I will order in a lot of patients is if I have a suspicion of vitelliform disease, I'll get autofluorescence. And a lot of time that'll help to show us the autofluorescent lesion prior to that. And sometimes if you don't get the autofluorescence and you just get the fluorescein, it can be a little bit more difficult to tell what's going on.
Yeah, we make our photographers do autofluorescence at the first of all the fluoresceins, because a lot of times it'll show you concomitant geographic atrophy that's causing vision loss as well. And so I think it's important that that happens. The other thing we always make them do is to do at least some choroidal imaging to see is the choroid really skinny, like age-related choroidal atrophy, or really thick, which in the presence of subretinal fluid could be another masquerade central serous retinopathy, even in somebody of age-related macular degeneration age.
The autofluorescence after the fluorescein looks quite different.
Yeah.
So that's how we diagnose and bring patients in terms of imaging for a new patient. We're going to talk about treatment a little bit later, but I'm interested now, follow-up. What imaging devices do you use for follow-up? Why don't we start with Dr. Boyer?
Well, for follow-up, I usually just get an OCT and compare it to the previous scans. If it's decreasing, I would continue to treat. I do a treat and extend protocol usually. So I treat till dry, and then I will extend them by 1 or 2 weeks, depending on the status of the other eye. If after several injections they're not dry, then I will bring them back in 2 weeks or double the dose and bring them back in 2 weeks and reevaluate them at that point to see if I'm missing some masquerade syndrome.